Our next speaker is Jessica Brooks. Jessica is the CEO of the Pittsburgh Business Group on Health. As I mentioned in my opening, one of our best collaborations since our first conference has been collaborating with Jessica and her group as a network to get the word out. And the more I have learned about the group, their mission is very similar in the sense of education and education of diverse groups that don't necessarily get together in the same room. So I'm very happy to have Jessica talk. And by the way, we just joined the group. I just got my login today for your organization. I'm looking forward to learning more.
Thank you. We always appreciate our new members, and you are more than welcome, and we're looking forward to collaborating with you. This is actually our second time collaborating with AMD3 in a year. In September last year around our symposium, we really learned of this organization and saw some really dynamic content that we wanted to be a part of, and really wanted to take this opportunity to partner together yet again and engage our employer members in the conversation of how we can empower employers to move forward. So thank you, and looking forward to us working together very closely moving forward. Before I get started, I really am excited, actually, after being here and being the last speaker. Sometimes that's not the best position. But our speakers prior to me, Jamie, Bill, and Diane, really set a tone for today, and quite an encouraging tone. Bill and Jamie started off with talking about direct contracting and reference-based pricing, all of the topics that we're covering and discussing and actually moving forward to implementing in one way or another at PBGH. So I'm going to speak to that a little bit more in detail shortly. And Diane talked about some of the consolidation ACOs, but really around wellness and engaging employees, ultimately patients, to you, many of you, and their care, and how to really activate the consumer. And all of that is important to the employer, and I'm happy to move forward with speaking to you further about that. Is there a... Well, I will start off with speaking about PBGH and who we are. And we are an employer-led coalition focused on championing outcomes and cost-effective health care in our marketplace. And we do that in a variety of ways, through collaboration, education, benchmarking. But really last year, our board, and we went through a strategic planning session saying, how can we really move the needle? We've been around for 30 years. How can we move the needle and help employers and empower them from taking the education we bring to the marketplace and activating them? And so you're going to see a lot more around data and resources and tools, benefit design strategies, as well as group purchasing to help our members save their dollars. We'll be talking about healthcare trends and some of those things that we've been talking about all day. What is driving up the cost? Why are employers concerned? And why are they now at a pivotal point where it's time to activate and move forward in a dynamic way? And then we'll get specific on some of the PBGH priority initiatives that we have on the table right now. I mentioned our mission, and ultimately our vision is to be a collective voice that drives optimal healthcare performance. We have over 75 employer members today, 412,000 U.S. employees, and over $5.2 billion in healthcare spend. And there's 55 coalitions, more than that, but those of us who are members of the National Business Coalition on Health across the country, this isn't chump change. We're not just small little Pittsburgh that some may think about, southwestern Pennsylvania. $5.2 billion is significant. About a third of that spend is here locally. 80% of our members are self-insured, and 38% of those members have an average of 1,000 to 5,000 employees. We have seen a unique, or I guess a diversified interest from different employers, AMD3 being one employer that's smaller. Traditionally, we've been primarily focused on self-insured over the past 30 years. Larger organizations, many of those you can see up here, Hines, U.S. Steel, PPG, Alcoa. And over the past several years, we've had a greater interest from fully insured and even smaller and mid-sized companies, some self-insured, some fully insured. as well as unions. A lot of pickup last year from unions being interested as purchasers and saying, hey, we're purchasers of healthcare as well. How can you help us, or how can we come together as a collective to really move the needle on the things that are burdening us as employers and purchasers of care? So as you can see, Aetna, Cigna, Highmark, United Healthcare, and UPMC Health Plan are all associate members of ours. Many of them larger brokerages and consulting firms and smaller brokerages and pharma companies, PBMs, they're all associate members. We do realize that it's going to take multiple stakeholders to move the needle, but we also realize that now more than ever, it's time for employers to have a voice, and a voice that carries, and a voice that has action behind it. Last year, we were very vocal about some of the local matters, and actually that was my first year in this role as CEO of PBGH, and I thought I was going to come in and really focus on the ACA and healthcare reform and Cadillac tax, I don't know. And it was really obviously what was happening locally that took the stage for us. And we really wanted to understand what our employers wanted out of the marketplace, demanded, and how we can represent their voice. So a lot of the national and even local stage or opportunities we had to speak on behalf of our employers did have to do with market consolidation, Highmark and UPMC obviously splitting technically, and the trend and what that would do moving forward and how that would impact not only the employer but the employee. And we do know that market consolidation has over time impacted price and price transparency, frankly. Not much attention has been put onto the quality and the impact of quality to that. At the beginning of the year, we really were focused on access. That was number one even before cost. How can we ensure access for our employees? And what can we do around that? And can we be vocal around that at least? And then cost came into play. But after we realized that things were going to be changing in our marketplace and moving forward, then we were concerned around transition of care and coordination of care. And as this transition happens, will my employees be okay? Will they be able to access care in an optimal way? And will they be able to afford it? As employers have made significant changes in their benefit design and the shifting of responsibility to the employees over time, that was a huge concern. What's in network, out of network, the basic things. And so when we talk about innovation and where we're headed, we do have to still understand there's those fundamental concerns that employers have that we have to address. And we're preparing to do that as an organization, as a collective. And we're realizing more that it is going to take the whole business community. It's going to take a collective. And no matter your size, you do have leverage. That was surprising to me as well. Although being a coalition, oftentimes we operated very siloed as individual employers, and we have employers very diverse, as you saw, on the continuum of some paternalistic, some real mavericks, some of them in the audience, I would say. I'm not going to call anyone specific out, but real mavericks, just moving the needle, being innovative, but oftentimes not realizing how we can come together as a collective and be innovative together, or take a stand together and hold our counterparts and sometimes often our advisors accountable. So what we're seeing is healthcare now being at the forefront within even our employer members at various levels. It is a business imperative. I'm not sure if anyone saw the PwC survey recently that showed that over 36% of private companies, CEOs, CFOs responded that healthcare is directly impacting their profit and growth. And of that 12%, significantly, they said healthcare is significantly impacting that, meaning they're not getting the profits they're expecting, their growth is being stifled, and that they have to do something in a very soon. Time is not on our side when it comes to that. And then, so that took me on this journey of understanding, well, how are we, when I look at different surveys, and depending on the consulting firm and the audience they have, you might see a survey and most of the respondents are HR or benefits managers, and then you see different responses when you hear from the CFO or CEO. And so we've been talking a lot as a coalition and really been speaking to our members and asking them, what would you like to see? And executive engagement are one of those areas that have been identified. How do we begin to equip our C-suite in understanding that it's more than managing at X% trend, that's not working for us so far, and that we need to do something together collectively, even within our own organizations. I spoke to one president, which I thought was interesting. He knew about private exchanges and some of the specialties, Sovaldi, and I was kind of surprised for a CEO to be in that level of detail. And so we walked on the journey of understanding how he got to that point. And he said, well, I started seeing the numbers, and that's what it started out as. And then I wanted to know where those numbers were coming from. And having an organization that has very low turnover, I really do care about my people. It's beyond the numbers. I know John, I know his wife, I know their children. And he said, but I saw John walking a little bit better a few months later, and I realized he probably had a knee replacement. And then those dollars started clicking, and I stopped liking my employees all of a sudden. And he said, so, I need to do something. I want to like my people, but at the same time, I'm pulled into this healthcare strategy in a way that I haven't had to really do that before. And I need a balance. I want predictability, and I want guarantees. And so I was encouraged by that conversation, but also realized we have a long way to go and that there is disconnects between the levels. I spoke to another CFO who said, for a long time I only really saw numbers, and that's just what it was. I saw numbers, and I said manage at this trend, and but now I'm asking for trends on my people's health and how we're benchmarking against our competitors. What are the diabetes rates? What's obesity? What's the impact? What are we doing around wellness? And I hadn't had that conversation for most of my career. And so when you think about that and really think about that, that's telling you how we've internally as employers been managing this healthcare strategy with the CFO and the C-suite leadership really not being as engaged as now they're realizing they need to be. So when we talk about the excess and waste and cost, we do, before pointing the finger, which we do, and rightfully so, we have to look in the mirror as employers and say, what are the dynamics within our organizations, and what's the level of accountability we've been holding ourselves to, and are we empowering the right people to be innovative and say yes to innovation and say no to things that are waste and the status quo, and sometimes that often is the folks who are advising us. And so that's some of the dynamics and things that I've learned a lot about last year, and we'll be focusing on as an organization, how do we engage the C-suite, and how do we empower the benefits and HR leaders to have those conversations, and really it boiled down to data, resources, and strategies that will actually translate into what matters to them about their business and about their assets, which are their people. So as a coalition, we will leverage that collective voice and really equip and empower employers through data. And some of the information I'll share to you is through partnerships that we're doing that. We are at a very pivotal point as employers, and employers are, as Brian Klepper, the CEO of PBGH, says, the counterweight to the healthcare industry. I do agree with that statement, but I also know that it's going to take all of us in this room, providers and health carriers, integrated delivery systems, ACOs, whoever's involved, and whatever the term is, at the table together to really do something. But when we talk about the healthcare trends and what's kind of driving us to consider direct contracting or reference-based pricing, it really boils down to consumerism and cost and lack of quality and lack of understanding what the price and quality is. I think the ACA, of course, accelerated that. We were always going to be at this point as employers and purchasers really focused on this in a different way, but I think that accelerated it, and obviously what's happening in our own market with two integrated delivery systems, provider consolidation, and those things brought even more to the forefront and actually elevated the conversation internally within our organizations. Diane touched on this a lot, and I think this is the point we really want to make. As much as cost and cost shifting has happened towards the employee salaries have almost flatlined over the past 2 decades almost. And that's something we have to consider when we're making these changes. And I say if there was a theme song to healthcare, it would be the electric slide. Shift it to the left, shift to the right. We're just shifting all around. And it doesn't take a rocket scientist to say, hey, employer, you can save money by shifting, and let's create an app for you, and you can monitor. It does take a lot more than that. It's understanding the dynamic workforce that are within the industries, within the employers, They're very different. You can't be treated, U.S. Steel and Westinghouse are two different workforces, two different types of environments that they work in, or a global company versus a regional company. And a lot of the innovations and solutions that have come to employers have been pretty much cookie cutter, whether their employer is a local company or a national or global company. We have health literacy on the table. That's an issue, cultural dynamics. Employers are not just covering their employees who walk through the door and sit in the cubes. They're also covering their spouses and their families. We have an increased multicultural family unit more than ever, and that's increasing more and more. By 2050, I think we'll be a majority minority country. And so the way we've been addressing the employee group benefit internally has to change, and our vendors, our health plans, our health carriers have to realize that when coming to the table to help us resolve these things, that we're working with a very dynamic workforce. We're covering dependents. We have high childhood obesity rates. How are you helping me engage them? Giving me an app at my desk is not going to help me when I go home and my family is an educator or engaged in a dynamic way. I think that's been a misstep, and I haven't heard much of that being talked about as I've gone around the country to really learn about what other markets are doing and how employers are addressing this and how their advisors, who are the consultants and advisors, how they're helping them to address that. I'm not saying it's not happening at all, but it's not talked about nearly enough. And when you talk about costs, oftentimes the dependents may cost even more than your direct employee. So our solutions cannot just be focused on the person we see. So when we talk about some of the things that we're looking at direct contracting. That is on the table. And when we brought that up last year, and we asked multiple stakeholders at the table, not even non-employers, to really understand what if we really did try to do something around direct contracting, what did that look like, and what are the concerns of employers? And it seemed like a big, heavy lift. And we've been talking about that a lot more. Is it partnering with telemedicine? Is that a way of direct contracting? Site of care and maybe partnering with a CVS or Walgreens clinic for acute care, is that direct contracting? Or do we go to UPMC and really try to negotiate a significant contract or AHN? So, and it's yes to all of those things. And I think that we have to kind of dissect that and realize what steps we're willing to take and what steps we have to take around that. And what are the barriers, given that we do have 2 integrated delivery systems? You may say, well, just go through our health plan and then you're directly with us. That is direct contracting. So beyond direct contracting, we're saying, well, what about high performance networks? How do we really drive and steer people to high quality providers at an optimal cost? And so that's on the table, and I'm proud to say that last year we really kind of took that serious and wanted direct contracting and driving high performance networks on the table as a discussion to see if employers would be interested, and we introduced that last September. And since then, I could say we have an organization who is definitely taking that very seriously and looking at the feasibility of that. And when I share that with other markets, they can't believe it's schools districts. That's your innovative market. And I said, yeah, they're very innovative in our marketplace, and they're moving forward. And although they've been managing their trend great, just because you've been managing your trend and you're not looking as bad as your neighbor doesn't mean that it's a good news story. And so they're saying, well, we need to do something even more impactful, and we have to do something different. And they're taking steps and really moving forward. So we just need one maverick, and it doesn't have to be the largest employer in your market to do something and say, hey, come aboard and kind of understand and learn more about this. So we're excited about that. It's not just a theory. We actually have some employers and some interest in driving high performance networks, and we've gone to the point of speaking to some providers, and we're still on that journey to say, well, if this did happen, what role would you play in this? And I'm happy to say that it sounds like our providers in our marketplace are willing to work with us as employers as we introduce some of these strategies and approaches. Reference-based pricing, we actually are rolling out with an education campaign this quarter around that, and I'll speak to that a little bit more. I think every employer has at least considered paying instead of playing in this healthcare game. We are seeing surveys and speaking to employers, and I haven't heard of any who truly is trying to get out of the game altogether. I know that they really see this as offering benefits as an opportunity to be competitive. If I get out of the game and my competitor stays in the game, am I going to lose some of my intellectual property and my human capital? So it truly is seen as an opportunity to engage their workforce and really add to their competitive advantage. But at the same time, it's not going to go off the table until we're able to really truly drive down costs and impact quality of care. I think every year, and multiple times a year, CEOs or executives will consider, do I pay or do I play? And so as long as that's an option, I think we as a community really need to understand how to keep employers as purchasers in the game in an affordable way. And so private exchanges, we have some employers who are deciding to go that way. Defined contribution, of course, is on the table. Employers have been going through consumer-directed health plans or high-deductible health plans. That's not going to go anywhere, and we do realize that. I think there's a wrong way to do it and a right way to do it. We are seeing some decreases across the country in funding the HRAs and HSAs when you have high-deductible health plans. So those are opportunities I think we need to look at, value-based benefit design. How do we incentivize our employees and give them the right tools? And that really is the call for why we're asking for price transparency and reference-based pricing, is employers clearly understand that we're pushing responsibility over, but are they equipped and are they ready? And what do we need to do to help them be ready? And that is transparency. We do need it. I know Jamie mentioned quality transparency and how that's difficult, and price maybe is obviously the way we can go right now. We can actually do something with that and understand charges and reimbursements. But quality has been and will continue to be a priority of ours. I was meeting with the CEO of a health system recently, and he said, it sounds like you guys are trying to do our job for us. And I said, the reality is we don't want to, but we just might, and if we do a better job, you better watch out. So I think that pressure from the employer community is really going to accelerate, I think, the willingness for providers to move forward with providing the right quality and price transparency that we need and we're looking for. Part of all of this is really how our mentality and a paradigm shift that we need around how we look at disruption. All of this is disruptive. It's uncomfortable. I'm smiling because I see the opportunity in the disruption, and I'm actually excited about it because for the first time we're kind of the wool's pulled over our eyes, and we're really seeing things a little bit more clearly and realizing we can do a lot better than we're doing as a nation, as industry, and as employers and providers of care. So looking at this as disruption, my call to action for everyone is to, even if you're advising employers and even employers, that when we measure what disruption is, that, it may not be, you may get a lot of calls to your office. It may not be the easiest thing to do, but if you have the right data and you know you're making the right decision, let's take the calls and measure that disruption as good disruption, as an opportunity to educate our employees who are trying to be informed consumers, and really not take maybe some innovative, seemingly disruptive opportunities off the table as a result of maybe not wanting the CEO to get a call. So I know that's hard and easier said than done, but I think that's a very, it's a missed opportunity and a difficult way of truly moving the needle if we're measuring disruption by the number of employees who may seem unhappy. And we obviously know that they aren't educated to the level that they need to be, and part of that onus is on us for protecting them for so long. So how do we help get them to a point of readiness? And that is sometimes maybe putting some disruption out there and having them ask the questions that they need to ask. So how we're leveraging this opportunity of disruption, we kind of see what's happening in our market as a perfect storm, and are really excited about working collaboratively even with the providers and the hospital systems and carriers around how we can move the needle and making sure they understand the demands at this point that employers have for the level of performance they expect from them. So we'll be raising awareness on price and quality variation across the Pittsburgh market. We are looking to use this data and information to empower consumers, and we consider as a coalition of consumers first as an employer. and for the employers to empower their consumers, which is their employees. So we're looking to kind of take that to the continuum and ride the wave of consumerism and actually get a little bit more proactive than we have been in equipping our employers with the right information, the right resources and tools, or at least thought leadership around some of these things. And some of that thought leadership is around transparency, reference-based pricing, direct contracting, driving high-performance networks, centers of excellence. When we say we're a collective voice driving optimal healthcare performance, we don't mean that just for employers. We are looking at this as a community and saying we should be the benchmark. Other markets are definitely looking at us. I get calls all the time from my peers across the country, even providers who are saying we're expecting consolidation. We're looking to buy a hospital system. We kind of want to see what you guys do in Pittsburgh and how it's working. I think we need to realize we're not in a bubble, as some may tell us. We are really out there in the open, and we're expected to do things in a dynamic way, and people want to learn from us. They don't want to just learn from our mistakes. So we really need to take this shift very seriously, so we can be an example for the nation, that the numbers that Diane shared don't look the same when we're compared to Europe and other nations as they do today. So what are we doing specifically at PBGH? I mentioned some of this, but we really in 2014 looked at some strategic partnerships, and one of that is a organization called Benefit Design Specialists. But basically that's bringing a transparent health plan in our market. I believe it was Bill who mentioned that in other markets there are employers as small as 10 who are self-insured. That's not really our reality here in the southwestern Pennsylvania, and I'm not saying that self-insured is the right choice for every single employer, but we really did realize there's a gap and an opportunity for PBGH to kind of look at transparency in a different way in the resources we're providing for our employer members. So we introduced this year, 1/1/15, a transparent health plan. Today they're renting the networks of a couple of the national health carriers to ensure that access. I'm seeing that and we're targeting employers 50 to 500, size 500. But I'm seeing it as an opportunity for us to really begin to negotiate if we need to, and take some more power and leverage and kind of flex our muscles if we need to work directly with providers and directly contract or implement reference-based pricing or create high-performance networks, leveraging these networks and these resources and tools. So that's very new for us, and it's a response to what's been happening. And another way that we're saying, we don't want to be in the healthcare space. We really kind of want to manufacture still or automobiles or whatever we do, or catch up. But if we have to, we're going to move the needle and be empowered and kind of move forward and directly contract or create some networks of our own. So that's one thing. Diane also mentioned specialty drugs and drug management. For 15 years, we've been in partnership and have a carve-out prescription drug program. We are looking at that, and we actually negotiate a very aggressive contract to get some of the excess waste out from a pricing perspective and a drug management and disease management perspective. But we're looking to evolve our program beyond just pricing. We do know that we have a very competitive drug pricing program where employers can save significant dollars. But we also want them to be able to have programs in place to help them manage the disease or the chronic conditions of their populations. Medical adherence is huge. We've had a long time focus on diabetes. So there are other things that we're looking at to evolve our prescription drug program. Site of care is also a huge component of that, and how you access some of the specialty medications and therapies. So those are some of the PBGH priorities that are already underway. And these three are really around our movement to equipping and empowering employers through data, resources, and tools. And we've partnered with several subject matter experts on providing some data and quality information in our marketplace. Comparian actually has, they have a system leveraging MedPart data and is scoring basically the hospitals, not at the physician level, but the hospitals, both from a national, and we can drill down regional. As I mentioned, 2/3 of our employers are national employers, so we can look at their regions and other markets as well. But we are focused right here in our market today. And there is a provider system who actually has taken this very seriously and actually purchased a tool themselves and said, well, if employers are looking at this, we want to understand what you're looking at and what you're expecting. And I think that's commendable. So we're at the very beginning of that, just rolling out that level of information. It is around quality, and we are going to push for greater results and greater data and information so we can be more informed. But to say, quality is hard, there's not really good ways to measure it, let's not consider it, we can no longer kind of take that attitude. We do have to look at quality at the same time as looking at price. So we're working with Truven Medical or Health Analytics on reference-based pricing and geographic price variation on shoppable procedures. And I think Jamie mentioned it earlier, where quality and cost are always align. So we're looking at 4 procedures this year: colonoscopy, endoscopy, 2 MRIs, spine and lower joint MRIs, and really putting out there the price variation. It's significant. When we looked at potential opportunities if employers were to take advantage of reference-based pricing, just for these 4 procedures, there was over an 18% savings, $5.5 million in savings just on these 4 procedures. And so that's significant. There's $14.2 million just on those 4 procedures we selected that we spend in our marketplace, and we have an opportunity to save significant dollars just if employers set a price that still provided access to quality providers and made providers compete, frankly, for their business and steering employees in that direction. But we know reference-based pricing and implementing that isn't the first step. It really is educating the marketplace around the price variation. So that's really the stage that we are today, and that's the commitment we've made. Our board said if we know this information, it would be irresponsible for us not to share it with the community. So, but we do see this as a multi-stakeholder approach. We are in the process of meeting with the health plans and the providers, being very transparent on our end on what we're looking at, those procedures, and understanding the potential barriers. And with market consolidation, there's obviously going to be barriers. There's very fewer independent sites and providers nowadays. So how do we really save dollars given those dynamics? So we want to have strategic conversations with our partners out there in the healthcare industry. And then Evaluate is a tool that has been around for a long time. The National Business Coalition on Health created it with coalitions like PBGH, and PBGH was a part of the initial inception of Evaluate, and it has now grown over several years to an evidence-based quality tool. We've invited all of the health plans in our marketplace to participate in this tool, and 3 of those 5 health plans have agreed, and that is Highmark, Cigna, United Healthcare. Very excited to have them on board as a partner, and looking forward to the results. We should have those in June. And we'll be sharing that with our employers along with the health plans. And we'll be working with them collaboratively on what opportunities do we have to work with you differently that we can move the needle. And we do understand that sometimes employers' decisions impact their scores. Generic step therapy is an easy example. If an employer is resistant to put that in place, but we're measuring the employers on or the health plans on how they're measuring pharmacy management, we do have to understand the employer's role in that, and we'll be educating and working collaboratively with the health plans. These are opportunities to say that we're not anti-healthcare industry. We understand we're in this together. We just want you to be in it with us. And at this time, I will take any questions that you have. Perfect.
Come back up in a couple of